Minutes after the event. Great. Looks like the recording has been started. So just a reminder, we're going to record the presentations for today. But we will turn off the recording at the time of questions. Okay, just wanted to welcome everybody to this Med-El and Pacific Neuroscience Institute event on referring for cochlear implants and partnering both with PNI and Med-El for patients who are starting or are interested in starting their journey for a cochlear implant. Today, you're going to hear from multiple speakers, experts, both Dr. Courtney Volker and Dr. Rebecca Lewis, and then Matilda Tranberg from the PNI team, as well as the Med-El team on some of the latest innovations from Med-El related specifically to cochlear implants. We will start with the PNI team and then the Med-El team for presenting. So at any time, if anybody has questions, please feel free to type it in the chat, and we will make sure to address the questions at the end when we have a Q&A. We will be mindful of everybody's time. I know everybody's very busy and we're on a lunch break. So please let us know if you have any questions and we will get started, starting with the PNI team.
Well, thank you, Frank. I'm Courtney Volker. I'm the cochlear implant surgeon at Pacific Neuroscience Institute, and we really appreciate it's nice to see so many people joining us during this precious lunch hour. This is our team, our main team. I'm Courtney Volker. Dr. Chester Griffiths is the co-founder of Pacific Neuroscience Institute, and Dr. Rebecca Lewis, who's our cochlear implant audiologist, who you'll hear from after the introduction. Next slide. So we also, in addition, have Chris Grothy, who's our clinical operations manager, Stephanie Espinoza, who's our surgical coordinator, David, who is our cochlear implant coordinator, who all are very important to the success of our program over the last 3.5 years. And our newest addition, Matilda Tranberg, who will sort of finish us off at the end of the talk. Next slide, please. So as we all know, hearing loss is completely undertreated. Less than 15% of adults who benefit from a hearing aid actually receive them. And the staggering 5 to 7% of adults who could benefit from a cochlear implant actually receive them. If you could mute your background if you're not talking, that'd be great. And there's a huge delay in treating hearing loss as well. So 5 to 10 years after initial diagnosis of hearing loss symptoms. Next slide. Here in the Los Angeles area, we are following the undertreating trends, unfortunately, and only 3,500 adults receive cochlear implants in the United States per year. Next slide. If you look at LA itself, we only are doing about 350 to 400 implants. That's all surgeons across the LA area. And if you can believe it, there are probably around 35,000 candidates in the greater Los Angeles area. So we need all of your help to help reach more patients with this amazing technology. Next slide. So now Dr. Lewis will take this portion of the presentation over.
Okay. So there's all these candidates that are out there that aren't being sent to cochlear implant centers, or people aren't sure what to do. So who is a cochlear implant candidate, I think, is the trickier question these days, because the candidacy criteria has expanded so much. So I'm sure you've had patients in your clinics that have said all of these things. I feel isolated because of my hearing loss. I feel fatigued at the end of the day, and that's for patients sometimes only with hearing loss in 1 year. So all of these types of things that patients say might spark the idea to consider referring to a cochlear implant center for an evaluation, or we team up with community audiologists all the time and work with them if they're interested in doing the evaluation themselves. So the pre-evaluation visit, once you send them over for a cochlear implant evaluation, is a team approach. It involves looking at medical indications and considerations, audiologic functioning, vestibular involvement, education, and of course the support system, the community audiologist or the family, colleagues. We lean on Medell a lot for support, and now we lean on Matilda, our outreach ambassador. So what happens during the audiologic pre-evaluation visit? At our center, we try to schedule the audiology pre-evaluation visit and the surgical consult on the same day. So it's a one-day evaluation. We look to determine, first of all, if they're audiologically a candidate, and we do that with aided speech perception testing. So we verify the hearing aids, make sure that they're fit appropriately. Usually we program our own hearing aids just to make sure that they're set correctly and that they're working well. And then candidacy nowadays, best practice guidelines dictate that they really should be based on aided word scores, so aided CNC word scores and quiet. So that determines candidacy, but we still need to do aided sentence testing for coverage because insurance is still looking at sentence test scores. We also administer several questionnaires to look at their functionality in day-to-day life. And because we are linked to brain health here at Pacific Neuroscience Institute, we also do a cognitive assessment on or a screener on some of our patients. So counseling is also done during this visit, and it's really the cornerstone of the whole pre-evaluation process, talking about realistic expectations, device counseling, what is a cochlear implant, how does it work, the difference between a hearing aid and a cochlear implant, so acoustic versus electrical hearing, what happens during a mapping visit, a follow-up visit, all of these sorts of things are covered during that very information intensive first visit. And that's why we lean on Matilda, that's why we lean on Medell to have these follow-up sessions with them as needed to just sort of reiterate some of this information. So who is a cochlear implant candidate? It might surprise you. Candidacy, like I said, has greatly expanded. We see patients across the lifespan, infancy to older adults. So I think our youngest implanted kids have been 5 months old to over 100 years old. And these are some of the indications that we've seen, medical indications for cochlear implantation that we've seen at our center. So it can be a variety of factors that lead to a cochlear implant and transitioning from a hearing aid. So cochlear implants, and Medell will go over how the implant works and the bells and whistles of their devices. But basically, the cochlear implant bypasses the damaged hair cells in the cochlea and helps patients hear better. And this is what we do when appropriately fit hearing aids are no longer providing enough benefit. And as you know, there's two parts of the system, the internal device that the surgeon places and the outside device that is needed to send the signal to the implant. And so when they take it off, they can't hear, and to hear, they put it on. So what I really want to dive into is candidacy because it's become more confusing over the last several years. So to do that and make it a little bit more interesting, we're going to talk about 3 different cases. This first one, this patient has had left-sided hearing loss for over 30 years with 0% word understanding and has never worn a hearing aid on the left side. And then the right ear has had a progressive loss and their word understanding was really affected on this right side. So the hearing decreased on the right and the word rec decreased on the right, and the left has never been aided. Right, that he's been wearing a hearing aid for a long time. So I guess the first question would be, which ear to implant? Since he gets nothing from the left ear and he gets a little something still from the right ear, that would be the next question, which ear to implant? So when we did the cochlear implant evaluation, the left side was 0%, just like it's been for 30 years. The right side showed aided CNC word scores at 38% and sentences and noise at 46%. So might surprise some people, but we actually implanted the right ear for a number of reasons. First of all, if the brain hasn't been stimulated on that left side, if the auditory pathway on the left side has been dormant for so many years, we run the risk of a cochlear implant not providing a whole lot of benefit. And then that patient is sort of stressed at the idea of even doing the second ear. And number 2, we know that because this right ear has been aided and because we've seen the decrease in hearing, we could predict very good outcomes with a cochlear implant because they've kept that ear stimulated and sort of primed and prepped for a cochlear implant. And this patient actually did quite well we implanted the right ear. We did the activation in less than a week following that, because obviously that patient had no hearing in both ears, but we routinely activate at 1 week follow-up. This patient might have been a couple days. And at 3 months following cochlear implantation, CNC word scores of 86%, and hearing and noise, which is really challenging with 1 ear, especially, at 72%. So this is another case. This is an adult male with bilateral progressive high frequency hearing loss. Grew to hate socializing. I'm sure you see patients like this in your clinics. They can hear, but they can't understand because they can hear the low frequencies, but hate how the hearing aids sound because there's so much distortion with those high frequencies. This patient begrudgingly tried hearing aids for a year and just was really frustrated by the whole hearing aid process, because this is a really tricky hearing loss to treat, but still desperate to communicate. So we did do a cochlear implant evaluation on this patient as well, and you can see these aided speech scores below. So the question is, which ear to implant? And in this case, we would talk to the patient also about hearing preservation. So especially with Medel's device, it's a very thin electrode array that so we can preserve cochlear structures and hopefully preserve low frequency hearing. And we know from studies that having that low frequency hearing can help with music appreciation, make the implant sound more natural. Also, having a functional hearing aid on the opposite ear can complement the sound quality of the cochlear implant. So we saw the aided scores were, poorer in the right ear than the left. So we went forward with a cochlear implant with hopeful hearing preservation. So we made it a hybrid where they were getting acoustic hearing and electric hearing on the same ear. And these were that patient's post-op scores. So you can see, I think the most interesting and dramatic improvement here was hearing and noise went from preoperative, like under 40%, to 3 months post, almost 80%. That's a big difference in noise, and that's in that bimodal condition. So hearing with the hearing aid in one ear and the hybrid device in the other ear. So that was really exciting for them. Then the last case I wanted to talk about is a 47-year-old female that had sudden sensorineural hearing loss. She was desperate to get her hearing back. We tried steroids. This was 6 months of time, intratympanic injections of steroids, really waited, hoping the hearing would come back, and it didn't. So we really decided, at this point in the process, we start talking about benefits and limitations of the different options that are available for her. So those options, as you know, are cross hearing aids, bone conduction, or now a cochlear implant. So cochlear implants for single-sided deafness or unilateral profound hearing loss have been really successful at helping patients get back localization of sound, speech, and background noise. And often these patients with a sudden hearing loss have a lot of tinnitus. And we know the cochlear implant most frequently will suppress that tinnitus because you're hearing sound and suppressing that sound in the head. And then, of course, we've seen dramatic improvements in quality of life measures. And I think Medel, Frank, you can correct me if I'm wrong, was the first to get SSD approved in 2017. Yeah.
Yeah,
So
that's correct.
so there's been a lot of research, and now it's not as unknown as it used to be to do this, and it really does benefit patients. While a cross is great in certain circumstances, a cochlear implant is the only way to restore bilateral hearing, and the binaural benefits of hearing and noise and localization is only going to come with a cochlear implant. And this patient, being only 47 years old, is also thinking to her future. Eventually, she'll probably lose some hearing in her only ear, so she wants to make sure she has 2 ears now. So some of the benefits of cochlear implants, we can pretty much guarantee that they're going to have access to sound. Their audiogram is going to look great. The part that takes time, patience, and practice is understanding what they're hearing. And we've seen that most research has shown that patients see really good results, improvement in all those preoperative tests by 3 months. And that can range depending on the duration of deafness, but on average, we see really amazing improvement by 3 months post-activation. Cochlear implants now are waterproof, so they can go swimming in them. They've got remote microphone technology available. So there's no limitations to what these patients can really do. This is an example of our follow-up schedule. This is another thing that's changed over the decades, that cochlear implants have been available with modern mapping techniques and the way that we work. We don't need to see patients every 3 months anymore. Really, we need these first 3 visits to optimize the sound quality of the cochlear implant, and then we can generally just see patients once a year after that, or even less, just for their upgrade visits. So we activate it 1 week post activate or post surgery. And then the 3 week post visit is my favorite because they've gotten used to the sound quality, and usually patients leave really happy because with some adjustments after that, they're really hearing well. And then at the 3 month post visit, we see this great improvement. We offer a 6 month visit to people who aren't doing quite as well, but usually then we just see them once a year. Um, Most insurance will provide an upgrade to new technology every 5 years, so patients can look forward to better technology, more sophisticated devices, better microphones, smaller devices without another surgery because they always make them backwards compatible. So you can look forward to better technology without any more surgery. People always ask a couple of things. One of them is, how do you know if a cochlear implant candidate will be successful? So here are some of the predictors of a patient being more successful. The duration of deafness, obviously, if a patient hasn't been wearing hearing aids or hearing anything for 30 plus 50 years, we have guarded expectations. Sometimes we go go through with it as long as the patient really understands the potential, what the expectations are, and they shouldn't be high. Consistent hearing aid use always is better outcomes because the brain and the nerve has been stimulated. And cognition, although patients with cognitive impairment should still be considered, we have to have also an expectation talk that it might take longer to achieve the benefits that they're hoping for. So I'll leave you with some myths. I've heard patients and even people in our community say things like, it takes over a year to hear well with a cochlear implant. So this is a myth. Research shows, like I said before, on average, people achieve excellent outcomes by 3 months post-activation. Another thing we hear a lot are patients have to wait a month to get activated. They have to sit there in silence. We activate it 1 month following surgery. There's really no reason anymore to wait that long. New surgical techniques. There's not as much swelling afterwards. So sometimes even for our out-of-town patients, we can activate same or next day. Patients have to refrain from swimming and other sports activities if they have a cochlear implant. Definitely a myth. Cochlear implants have waterproof accessories. Patients don't need they don't need to limit their hobbies or their activities at all. Patients always worry about the phone or going to work after a cochlear implant. Now, cochlear implants have direct streaming for phone calls, same types of things that you talk to patients about with hearing aids. And, generally we see our patients going back to work within a week after, or as soon as they get activated, even if it's not perfect right away. And then finally, patient is too old or has too much cognitive impairment to benefit from a cochlear implant. Myth. So we implant as young as 5 months old, and we have a patient right now that we're evaluating that's, in their hundreds. And treating hearing loss appropriately actually is the #1 modifiable risk factor for cognitive decline. So treatment can not only, improve hearing, but it can reverse cognitive declines and improve brain health, which Dr. Hooker is going to elaborate on now.
So thank you, Becky. So, when I was getting trained in fellowship, we used to think that any amount of cognitive decline meant a patient is not a candidate for cochlear implantation, which is totally false now. We know that, as Becky said, hearing loss is the #1 modifiable risk factor and contributor to cognitive decline. So it's really our duty as physicians and audiologists to treat even the most mild amount of hearing loss. We'd never let people walk around with even a little bit of blurry vision. We always put prisms and glasses on. But for some reason, we let people walk around with blurry hearing, even severe hearing loss. So we have to change the paradigm. Next slide. We know that hearing loss is associated with depression, anxiety, reduced social activation, social isolation, inability to work, loss of independence. Actually, balance is affected and a fall risk is increased. We've talked about dementia and cognitive decline, and even is linked to cardiovascular disease, diabetes, and amazingly, an increased mortality. So we really need to be aggressive in treating hearing loss at all levels. Next slide. So can hearing improve brain health? Yes, it can, and we're all responsible for helping folks do better. Next slide. So this is the most amazing study that really changed the way I counsel folks. If you test patients' cognition, all ages, all levels of baseline cognitive scores at time 0, and then no matter the level of their hearing loss, mild, moderate, severe, profound, and treat them appropriately, either with well-fitted hearing aids or cochlear implants, and wear those devices for 10 hours or more a day and retest people's cognition at as little as 6 months, almost 100% of people's cognitive scores go up, no matter where they started. So when I tell patients this, even folks very cosmetically concerned on the West Side, they say, "Where do I sign up?" Next slide. So, Becky pretty much went over this already. How do cochlear implants work better than hearing aids? Obviously, we start with hearing aids on the front line, but when they're just not getting that benefit, we need to bypass the hair cells and directly stimulate the neurons with a surgical procedure. Next slide. So we already talked about the age. We're implanting as parents are finding us. They know that their baby is born deaf. Why are we waiting even 6 months now? As soon as we can prove that that baby can't hear, we really need to get that child implanted, regardless of you know popular guidelines, etc. And then you really look at the patient's overall health. At our center, we do not have age cutoffs. We look at each individual patient. There are very young 100-year-olds, if you can believe it, and there are folks in their 60s with terrible comorbidities and health problems. So people's chronological age does not really dictate what their overall health is. And as long as they can withstand a 1.5 to 2.5 hour procedure under general anesthesia, we'll go ahead and proceed. Next slide. So I can't afford to have the surgery. I can't pay for this, $40,000 device. Well, if you can believe it, Medicare covers this 100%, and all PPO insurance cover 100%, even single-sided deafness with the private insurance. We're still waiting for Medicare to fall on that one, but we're keeping a list and watching those patients very carefully, because as soon as Medicare falls on that, we're going to circle back around and get those people implanted. Next slide. What needs to be done before surgery? So, since most of the folks here are audiologists, I thought I would take time to just quickly run through my part, the medical and surgical part here. So, of course, they start with Becky Lewis, or any of you folks that have the background on cochlear implant evaluation. And then they'll come see me for just a general overall check. They need to have clearance from their primary care doctor or cardiologist regarding that general anesthesia. I order MRI and CT scans, and we go ahead and vaccinate them. Prevnar 20, just one shot. We don't need to do the 2-shot series anymore to prevent meningitis. And then we really like to look at that. We've changed our protocol. We really like to analyze the length of the cochlea, and that's where MED-EL is really the leader in the field on this, which they'll talk about. I've been amazed, especially over the last 3 to 5 years, starting to do this, in noticing the variety of lengths of people's cochlea. And if you only have one length of cochlear implant, you're not really getting full cochlear coverage for all of that sound frequencies. I had a gentleman last week who had a 36.5 cochlea. millimeter cochlea, and if you're not familiar, that's the longest cochlea I've ever seen. I think the average is, you know, around 30 millimeters, and you look at the ruler and you say, well, millimeters, but Med-El's just come out with a 34 millimeter array, and our program was the first to get that long array in that person's cochlea. So it makes me think, you know, boy, if we're inserting shorter and much shorter electrodes, how would those patients really perform? So I know Med-El's going to talk about that a little bit more. Next slide. And then I'm really scared for the surgery. You know, it's hard to make that jump from hearing aids to an invasive procedure. You know, the language that you all use could be really helpful. You know, it is a surgery, yes, amongst professionals here, but I like to speak about it as an outpatient procedure. I think people can relate to, you know, cataract surgery, colonoscopies, all of that sort of thing. I rarely have to admit someone from the hospital. I can count them on my hand. This is an outpatient procedure, about 2.5 hours, general anesthesia. Anesthesia is very safe nowadays with our protocols. And you know, we're now using minimally invasive techniques, just a few centimeters long of the incision behind the ear, making a tight pocket. You know, no more of these large craniotomy scars when I was first being trained. So these are minimally invasive techniques. Common side effects, obviously, it is a little incision. There is some bruising, numbness, swelling. Some people do notice some little bit of imbalance afterwards, which is usually self-limited. And the big risk is loss of residual hearing, but with our electrode profiles getting more and more narrow, and our techniques are getting better and better, and then a little extra steroid on board, then people tend to do very well. You know, uncommon side effects, knock on wood, I've never had an incisional infection. I've never had to take out one of my own implants due to infection. You know, but that is a risk, generally speaking. Meningitis used to be a much bigger risk, about 15% before we would vaccinate people. But now that we vaccinate people for meningitis, I can't think of a case we've had in an adult of meningitis. And then there is a risk of taste change. I am working around the taste nerve and the facial nerve. I've never had a permanent injury of the facial nerve doing this surgery. Next slide. So here's the CEO of Med-El. He came to watch us do a surgery when he took over leadership. That was a great honor for me. And these are, you know, some of our great patients ranging from really young to a little bit older in age. So just a miraculous technology. Next slide. I want to thank you for your time. You know, if any of you actually want to see a surgery, I put that out there to contact me. I can set that up for you so you can better counsel your patients. We really look forward to partnering with you. You know, we are an outside in, sort of inside out sort of model. We're willing to meet you on basic referrals. If you all want to do your own evaluations, we have our Tuesday morning chart review where everybody is welcome at 7 a.m. on Tuesday mornings to discuss patients. I'm there. You have access to me, you have access to Becky Lewis and our whole team. You know, David and Stephanie have been amazing to really get people in an appropriate fashion. We're not waiting months. We're getting people in within the month. White glove service. And Matilda's been an amazing addition to our team. She can come to your office. She can come be an ambassador to support patients. She'll talk to you about her lip reading class. And with that, I wanted to hand you off to Med-El to talk about their amazing Oto plan and all their different electrodes. So thank you for listening to me.
All right. Thanks, Dr. Lewis and Dr. Volker. Before I hop on to our slides, I just wanted to give a friendly reminder to those who haven't yet to put your full name, first and last name, as well as your email address in the chat box. And that will be the way that we can ensure you get the certificate of attendance. Let me go ahead and share my screen. Okay. So myself, along with Nina Harris, we're going to be talking a little bit about Medell's latest innovations. So I'm Emma Movick. I'm an audiologist and I'm a surgical account manager with Medell. So I just want to start by talking about our electrodes. And truly, first step in any CI experience is making sure that we get the right electrode length. And so we want to make sure that the electrode is delicate, making sure that we're having structure preservation. And so that's one of the hallmarks of our electrode is making sure that we're giving this gentle insertion as well as having all of these different lengths of arrays. So with our portfolio, we really think it's not a one size fits all. Another way we talk about it is different feet have different shoe sizes. So everybody's cochlea is a different size, and we want to make sure that the electrode is fit for each individual person. So in our electrode portfolio, we have 6 different lengths. So they go from 20 millimeters in length up to 34 millimeters in length. So for some of those bigger cochleas, like the 36 millimeter one that Dr. Volker saw last week, we can really help to accommodate that size of cochlea. One of the ways we do this is by using Otoplan, which I'll talk about in a little bit, but it really helps to give us that confirmation of what electrode length is going to be best suited. So other than us having all of these individualized electrode lengths, with our electrode, it's going to be soft and flexible. So 2 factors of this is first, the flex tip technology. So it's really going to go in smoothly, make sure that we're having structure preservation, as well as we have all of these wave-shaped wires in the electrode array. And that really ensures that as the electrode goes into the cochlea, it's forming to the shape of the individual cochlea. So it's following the path rather than pushing through. Another exciting thing we want to talk about is that we have FDA approval for proven hearing preservation. So we've known that our electrode arrays have structure preservation, but now we can show that they actually have proven hearing preservation as well. So just as a little history, for previous indications, our electrodes were approved for severe to profound hearing loss or profound single-sided deafness and asymmetric hearing loss. And so that would be those electrode arrays for that specific hearing loss range. We then had patients that had good low residual frequency hearing, and so they would have an indication for EAS, which means that we're stimulating the high frequencies, but those low frequencies are still natural because that is where they have the residual hearing. Before, they were only approved to use either the Flex 20 or the Flex 24, which are the shortest of the electrode array portfolio, so that it would give that high frequency information, but not get into the range of the low frequencies. But with our expanded indications, we get to have this fun combination of the two, so we can overlap those 2 audiograms as well as offer any length of electrode array. And we're ensuring that that will give that hearing preservation in the low frequencies. So patients with low frequency hearing can still benefit from a longer electrode array. The other thing to talk about is we have FDA approval for expanded access. So not only the hearing preservation claims, but we can talk about what those expanded access indications are. And so it's indicated for patients with moderate to profound sensory neural hearing loss. So in the low frequency, that's defined at 250, 500, and 1000 hertz, and it should be 40 dB or worse. In the high frequencies, so 3000 hertz and above, should be no better. The pure tone average should be no better than 65 dB. So candidates should obtain limited benefit from hearing aids, which we're going to define based off of the CNC words. And so in the ear to be implanted, the CNC score should be 50% or less. And then in the non-implanted ear, the score on the CNC should be 60% or less. And so again, exciting things with this is we are the only company to do our indications based off of CNC words. As well as MED-EL is going to have the widest CI criteria in the industry. So candidates with moderate to profound hearing loss can benefit from long electrodes and complete cochlear coverage. They no longer have to pick between the two. And then the other question being, how do we ensure we're getting the right electrode for the patient? So there is a free service within MED-EL where we can take CTs and MRIs of patient scans and actually determine what the CDL, the cochlear duct length, is for a specific ear. And that way we have all this image-based information to better determine what length of electrode is going to be best suited for a patient. After the fact, once they're implanted, we can actually use a post-op CT and determine where that electrode is in the cochlea to better determine how to adjust the frequencies so that it aligns with their natural tonotopic organization. And so I know we've been talking, like too quickly. I know we've been talking a lot about long electrodes. What's the point? Is it really going to make a big difference? And so we have two sound analysis that show why that low frequency information is so beneficial for patients' quality of life, for how they perceive these sounds. So we have a music sample. So this one is for shown with the low or with a short electrode array. So that shows that we're getting an idea of what the sound is like. We can kind of imagine what the song is, but we're just not getting that full sound, those bass sounds. Want to make sure, were people hearing that sound sample? Okay, cool. I'm getting some thumbs up. So it's just showing that, yes, we can hear the sound, we can hear the music, but I don't think it's ideally what people would want to listen to. And so if I switch to this one, so same song, sounds that really just give more of that well-rounded sound, make it a more enjoyable listening experience, more like natural hearing. And that's really the main goal within MED-EL, is that we want the patient to have the closest to natural hearing. So it means having that natural sound quality, speech perception, music perception, sound localization, best overall benefit. We want patients to not only understand speech, but really understand the whole world and hear things that way. So I'm going to hop it over to Nina, who will talk more about the externals of the device and all of the things happening.
Great. Thank you, Emma. Just making sure, can everybody hear me okay?
I can hear you.
Yes. Okay, awesome. Great. Thank you. Okay, so yes, thank you, Emma, for going over the internal device. And I wanted to just mention, so my name's Nina Harris, and I'm the clinical account manager working with Pacific Neuroscience Institute and many centers in Southern California. And so my job is to go into different clinics and work with audiologists just like yourself. So if you ever have any questions about MED-EL specifically, please do not hesitate to reach out to me, and we can chat more about it. But now we're going to transition to talking about the processors. And we joke on our team that, when you're selecting a cochlear implant company, you are marrying the internal, but you're dating your processor. The internal device is what's going to be in your head for the rest of your life. So you should choose wisely and you should get comfortable with that decision. But then the processor is what will change every few years, just as was mentioned before, with updates technology and with insurance covering a new processor every 5 years usually. So we'll move on to the next slide and get into the processors that your patients would be dating when they get a MED-EL implant. We recently launched our newest behind-the-ear processor, the Sonnet 3. This is the most recent behind-the-ear processor that's available on the market, and we are so excited that people seem to really love it so far. As you can see, it looks similar to most behind-the-ear processors that you've seen, and it also is typically within a patient's comfort zone if they like having something behind their ear. A couple things that set it apart are that, I don't know if it auto advanced. Okay, great. A couple things that set it apart are that it is smaller and lighter weight than ever before. It's really lightweight compared to the other behind-the-ear processors that are available as well. And something that people seem to really love so far is the ear hook you could see before. It is flexible and it has a wire inside and it's soft silicone. And so it'll latch onto the top of their ear for extra retention. Thank you. A couple other things about it, just as Dr. Lewis mentioned before, it is waterproof. So this device can go with your patients as they're enjoying water. And we also provide water protection sleeves in the kit as well when they get it. So if they want to do a lot of active water sports, they can. This processor also has an on-ear control. So if they're used to adjusting programs on their hearing aids, they can do that with this processor as well. And we also have lots of full day battery options as well as integrated streaming. So this device can stream to both iPhones and Androids. You can switch slides, please. Thank you. And then a lot of patients don't want something behind their ear. When they transition into a cochlear implant, a lot of people are really excited to have something that just is on their head and they don't have to worry about having it behind their ear anymore, especially if they are glasses wearers or if they, I know especially during, COVID with all the masks, we saw a lot of people want to have something off their ear and on their head. So what this device is, this is our off the ear processor. This is the Rondo 3. Both both microphones as well as the stimulation come from this one processor. It's also lasts a full day on one charge. It charges on a charging pad that comes in the kit. And it is also, really easy to troubleshoot because it's just one piece. The mic cover does come off and you can get lots of fun colors like this one, or you can get ones that blend in with their hair. And this device is also waterproof, just like our Sonnet 3. Every patient in California, if they get MED-EL, they can get 2 processors. So a lot of patients will get one of each to see which they like best. And then within the first 3 months, if they don't like one of them, they can swap it out and get a second of the other one. And this device streams with a little adapter that plugs into the bottom. Perfect. Okay, so we also have 2 apps that will function with these processors. We have the Audio Key 3 app, which is the app that can change their volume and change their programs. It also has a Find My Processor feature if they lose their processor, which is really nice, as well as some other things that, it basically functions as a remote control plus a little extra. And then our HearCare app is an additional app. It's the gateway to remote programming. So if you have patients who don't want to drive, P&I with Dr. Lewis, she can do remote programming for these patients if they're the right patient for remote programming, and depending on the appointment, they are able to work with patients who come from far away. And this is something that this app would enable. This app can also do an independent system check and an independent processor check. So your patients at home can check to make sure everything is working well. And then we do have a partnership with Starkey, and it looks like something got a little funky on this slide, but I'll just talk through it. So we recently launched a partnership with Starkey. So if you're used to using Starkey, then this is great news for you. What it means is that you can still program Starkey, and you can still use Starkey with your patients who have Med-El. So especially for our iPhone users, if they would like to keep their Starkey hearing aid, they can. And also if they would like to stream bimodally from their hearing aid, or from their iPhone rather, so iPhone or Android, going from the phone to hearing aid on one side, cochlear implant on the other, we can do that with Starkey for iPhones and for Androids. But then if we go to the next slide, we can also see that with Android users, Androids can connect to multiple devices. So we can connect our Sonnet 3, Sonnet 2, Sonnet, and Rondo 3, as well as a compatible Asha hearing aid to their Androids, to make lots of flexible streaming options for your patients. And if you have any questions, we can talk more about that too. One of the things we also want to remind everyone, and we want to remind patients as they're going through this process, is that we are a resource for them. Throughout their lives, they might move, they might switch clinics, they might need extra support, they might need, lots of other things. And we have people on our team who are dedicated to making sure that patients feel supported at home. We have Med-El Mondays, which is a class that they can sign up for, where they can come and learn about their processor, learn about their equipment, learn about rehab, learn about the apps. And then we also have one-on-one appointments where if they would like to meet with an audiologist individually over Zoom, they can get to know and troubleshoot and solve any problems that they might run into. Or if they would just like to get to know their equipment a little bit better, our audiologists are ready to go. And this can be done in 43 different languages too. We use an interpretation service. So really inclusive. We want everybody to know that when they get home, when they have all of their equipment, they're not alone, and we're here for them. And I believe that wraps up our portion of the presentation. And we'll just leave you with our mission statement at Med-El is to deliver leading edge technology to restore hearing and empower connection. And I think that empower connection is something that is deeply important to all of us who work at Med-El. We are here to help people communicate better. And we want to do that with our technology internally and externally, and with the support we can offer. So with that, we'll hand the mic back to Matilda, and she can talk about her program. Thanks.
Thank you, Nina. Thank you. I want to make sure that you see my screen and you can hear me well. First of all, can you hear me fine?
Yes.
Perfect. I think I've met most of you guys here on the call, but I am the outreach ambassador here at the Pacific Neuroscience Institute. I have 2 cochlear implants myself, so I can really tell that it is life-changing devices, and that's also why I'm very dedicated to work in this field. I wanted to share some of the resources that I provide for the community and for you guys. So first of all, I am hosting a free lip reading course every Wednesday in Santa Monica. So I've done it for quite a few months now, and it's a lot of different patients with hearing aids, with cochlear implants, but also just people who are really struggling with their hearing. And it has been kind of a support group, but we are also really looking into lip reading and getting communication skills. So it's a really nice group of people, and it's of course for you to use for your patients as well. I have put my contact information here as well in case if you need my help for anything. I mostly work with both Med-El, our center, we work really closely. But if you want any of your patients to have someone to talk with who have been in their situation, like a mentor, then I have a lot of good ones that you can reach out to me and I can give the information. If you need any other helpful resources for your practice, please reach out to me as well, since I am really a support for the patient who are struggling with their hearing. Also, I've been meeting you guys in person, but if you need more education or knowledge about cochlear implants, then we're really focusing on our center at a community-based program. So we really want to educate the community, give our resources, and also our knowledge. So our Dr. Lewis and Dr. Volker are very happy to set up a virtual meeting, or even you guys can come in for a day or half a day to shadow a cochlear implant evaluation to feel more confident talking about cochlear implants to your patients. Another thing I'm doing is Mondays with Matilda. It's another thing where I really do support patients if they need more education, if they have problems with the equipment, or just anything related with cochlear implants or hearing loss in general. Then I have this flyer, and I would be happy to come by your practice to give out more. Lastly, I want to wrap up with our upcoming event that P&I and Medell host in September. It's on September 8th, and it's going to be an in-person event in Culver City where you guys can give this information to any of your patients who are struggling with their hearing or with their hearing aids in general. This event is really all our team, Dr. Volker and Dr. Lewis and me, as well as Medell, will be there and kind of go over some what is a cochlear implant, what are the process, and so forth. But also the most special thing of this whole event is that we have some of our recipients who will come and share their personal experiences with their cochlear implants. So if you need any of these flyers or need any more information, please reach out to me and I would be happy to come by. I think that is all we have for today. But if you have any questions or anything, please let us know. I think we have a couple more minutes.
Thank you, Matilda and team. Appreciate everybody's time today. Are there any questions? I don't think I saw any typed in. Or if anybody would like to receive this flyer for our candidate event that will be taking place on September 8th, please just indicate in the chat and we can send it to you if you have some candidates who may enjoy meeting other cochlear implant recipients, as well as meeting the P&I and Medell teams. And keep in mind, parking will be covered at the event, and there'll also be light refreshments for people who wish to join. It'll be at the 4 Points in Culver City, just across from the Culver City Mall. So it's a convenient spot for families or people after work needing a place to maybe even grab a bite to eat after or before.
Someone in the chat just wrote also in Spanish if possible, and that's a really good plan. If we don't already have the flyer in Spanish, I'm sure you guys do.
Yeah, we're happy to provide that for you. And then also a reminder to provide us with your name and email so we can follow up with the certificate of attendance. And any additional questions? Just checking on the chat.